Hello, greetings, and welcome to the EHE 360 Global Conference. I am Denise Robinson, Executive Director of the EHE Foundation, and I want to start by thanking our conference sponsors, Adi Biosciences and SpringWorks Therapeutics, whose support has helped make this event possible. I also want to thank our generous donors whose support of the foundation makes this event possible and sustains our mission every day. And last but not least, I want to thank our presenters who have generously given their time to be here with our community today. We are grateful for all of you. I want to tell you a little bit about EHE 360. EHE 360 started several years ago as a patient-led collaborative network. It's a project of the EHE Foundation and has grown into a sustaining collaborative educational forum. If you're not familiar with the EHE Foundation, this foundation is dedicated to advancing research that aims to find better treatments and a cure for epithelioid hemangioendothelioma. Ultimately, our goal is to improve lives. We carry out our mission by funding and supporting global research and by providing supportive educational resources for patients and families around the world. Really, patients are the center of our mission and everything that we do every day. I want to tell you a little bit about this conference. So EHE 360 is a two-day conference. Today's Science Symposium will focus on translational research and data science. Tomorrow, we're going to feature a clinical care summit, which includes supportive care to improve outcomes for people with EHE. I am very honored to introduce our keynote speaker today, Dr. Wei-Wu Chen, who is a passionate medical oncologist and researcher at the National Taiwan University Hospital. Dr. Chen joins us from Taiwan this morning. He actively studies sarcomas. In particular, he gives his time generously to improve outcomes for people with EHE, and I want to welcome Dr. Chen to the stage. So thank you very much for being here today, and welcome everyone.
Thank you, Dennis. And thank you, everyone, for joining for the EHE 330. I'm Dr. Tom Chen. I'm a medical oncologist at National Taiwan University Hospital. So let me share my slides. Okay. Yeah, so it's really an honor to be here at the EHE 360 to share, our understanding of EHE and what we have done, or the group, or actually a lot of our investigators and physicians around the globe have done for our EHE patient. And of course, we want to provide what Denise said. We want to provide a cure, better health for all our patients. So today my talk will be building momentum in the research to improve outcome in EHE. But maybe I'll start with, what's this in the name? So we all get to call this EHE, but it's actually a very long name, and it's called epithelioid hemangioendothelioma. When you see this name, a lot of patients ask, what does this actually mean? A lot of times in these kind of sarcoma types, a lot of the names is represent what we see under the microscope and what it behaves like in what kind of certain cells in for this cancer. So for EHE, epithelioid stands for what the cell looks like. And hemangio is more like, it's called in kind of Latin word for blood. And endothelio, again, it's called the Latin word for the inside surface of vessel. And oma is something we call like a tumor. So this tumor was initially found to be more like in the cells like round epithelioid-like cells, and it has this stance that it times goes like this, like the vessel. But there are other what we call the vascular sarcomas. Why do we have to separate EHE from different sarcomas, what we kind of from vascular sarcoma called angiosarcoma? I'm using here, a Labrador and Golden Retriever as kind of examples. We know both they are dogs, but based on its difference that appearances, we know they are separate entities. So again, for EHE, something like this, or we know that they have similar effects with other cancer type that also comes from the vessels. But now we do know that based on how it grows and how does it affects patient's survival and what is clinical course, definitely these two cancer types. One is called angiosarcoma. Angio also means vessel. The other is EHE. So growth, angiosarcoma is more rapid, aggressive. For EHE is more often indolent, but it could be variable. For survival, angiosarcoma actually does have a worse survival compared with EHE. A lot of EHE patients do live very long, even decades. Course, through the clinical course, angiosarcomas, they are more very likely to be very aggressive. EHE, like I said, they are a little bit unpredictable. Most of the time, we do believe it's more indolent, but sometimes they could be aggressive. So we have to make clear that also these two are all what we call vascular sarcomas. They are different. Right now, even more, we do know that EHE within its genome, the DNA, they have specific what we call gene fusions. When we say it's fusions, it means that two genes are connected together. So 90% of the EHEs actually has these two genes, what we call the WWTR1, also called TAS gene, fused together with CAMTA1. When these two genes fuse together, it had this extra function that they can give the cell the proliferation, the proteins or the things that energy that it needed to growth. Another 10% of EHE, they have these two different genes we call YAP1 and TFE3 fused together. So most commonly when we talk about diagnosing have EHE, not only it has to be like have some kind of what we call the vascular cell markers. Now they mostly, at least they have to have these gene fusions. Either this is the COMTA1 fusion, the WTR and COMTA1 fusions, or the YAP1 TFE3 fusions. So right now we do know that these EHE is a very separate entity, and it can really be recognized by the fusion genes that it has. Also, EHE is sometimes we call the ultra-rare sarcoma. Sarcoma itself is already a very rare cancer, but what we call it ultra-rare sarcoma is a sarcoma histology with an incidence less than 1 out of 1 million person. So let's take example. So EHE in Taiwan, the incidence is about 0.38 out of 1 per million. But if we compare to breast cancer, which is a very common cancer, it's 1,325 out of 1 million. That's a 3.5 thousand times of differences. So you can kind of feel that how ultra rare EHE it is. Again, if I'm using Taiwan, here's Taiwan with the map, we're very close to China. We have 23 million populations, but this is the Taiwan National Cancer Registry, and this is the absolute patient number. So although we're seeing a kind of increase in the number of EHE patients because of diagnosis, but I want to say is that in 2016, what we have each year is only about 12 to 14 patients, EHE patients newly diagnosed each year in Taiwan, under 23 million. So that you can get a sense that it is a really an ultra rare sarcoma. And because of its ultra rareness, around the globe, now experts and spearheaded by Dr. Silvia Staglioli in Italy, we're now having what we call an ultra rare sarcoma working group. We call the PUSH project. This project trying to put forward all the ultra rare sarcomas, including EHE. And I have to say, actually, EHE is one of the first projects I think that will be completed here in PUSH program. And this is something we'll talk a little bit more later in my talk. So this is the PUSH project emphasizing on the ultra-rare sarcomas. But how can we help patients with ultra-rare sarcomas such as EHE? There are 3 points that are going to talk how we learn and how we help our patients. First, we learn from our patients. When I'm saying that we learn from our patients, I'm taking one example. The example is that EHE patients, sometimes in the later stage, they develop some effusions. So when there's fluid in the lung cavity or there's fluid in the belly, we call that effusion. If it's the lung, we call it the pleural effusion. If it's the belly, we call it ascites. And when patients have these outcomes, they do seems to have a worse prognosis. However, how to measure these effusion is really not built into the routine oncology clinical practice. A lot of times when we see how tumor progress, we measure by tumor sizes. So we know it's like, oh, it's from 5 centimeters, like shrunk to 2 centimeters. that we know that is 60% less. But how do you measure the fusions? But we do know that fusion is a very important. If there's a fusion development in EHE patient, we have to be careful because it is associated with a kind of worse prognosis, worse outcome. Patient with the effusions have to be careful. They maybe have a more aggressive disease. So trying to measure this, Dr. Andrea Venzulli, also from Italy, from Italy National Cancer Center, together with an expert, he developed what we call the rescore. So rescore is trying to learn from our patients to build into how do we measure these effusions. So you can see on this, on the left-hand side, the figures, the green arrows, you can see these are very slight, thin, like fluid-like. They're really hard to measure. But thanks to technology, right now, we can really measure this in 3D fashions. Because of the scan, you can capture this. So you can compare whether your lung volume, because when you have more fluid in the lung, you may have a lower lung capacity, like you're harder to breathe. So you can use this to really measure how that changes. You can even measure the linings, it is by that. But we have put this into the scoring. So that's what we call the rescore, a different score that we normally use in clinic, how to measure the tumor has changed. So this is really specifically for our EHE patient, for us trying to understand our is our drug really improving the effusion? Is it helping the patients so that we can have a better, more pinpoint estimation of how the disease is progressing and how our treatment is helping our patients? So this is why we're said that we're learning from our patients because we're seeing what our patients having this disease and how we can really do to measure this so we can have a more precise understanding how the patient is doing. So that's very important. So for us to find new drugs coming. Second, we learn from experience. Why am I saying this? I'm just taking two examples. I know sirolimus. So sirolimus is actually a drug first used in transplantation, where they use to help suppress a patient who had received an organ and to suppress their immunity to attack the donated organs. But by experience, again, the Italian groups, they found out that sirolimus actually works in EH patients. So they have reported up to like 38 patients, EH patients, using sirolimus and how it had helped these patients. And within that, what you can see is that they showed a picture, very interestingly. The dark area here is the tumor, EHE in the liver. We know EHE could develop in the liver. And with the use of sirolimus, you can see this tumor is shrinking. And once shrinking, they kind of collect this patient. 10% of these patients, they have a tumor shrunk more than 30%. So that's 4 out of 37 patients. But if you see that tumor actually stabilized and did not progress, that is 24 out of 37 patients have tumor stabilized by using sirolimus. To be honest, we really does not know why it is working, but by learning by experience that sirolimus is now accepted in a lot of global institutions like my institution, that it should be considered as one of the treatments, standard treatment for EH patients. So that's why we learn from our patients. Again, this is the what we call the survival curve, or more to be explicit, the Kaplan-Meier survival curve that we're showing how patients are doing. So once a patient has either disease kind of progressed or actually has died from the disease, we kind of go step lower. So if this line can go like as horizontally as long, that this is how we measure this outcome. So when we say progression-free survival, that means that the half of the patients using sirolimus could have their disease under control and survive for 30 months. That's half of it. Then when we say overall survival is that starting from the patient receiving sirolimus, half of the patients survive for 18 months. But what we see is that there's, and this is the outcome. And in Taiwan, how my institution, our team has been doing is that we use specific techniques to stain on the EHE tumor samples. And you can see all these bright spots. Why is sirolimus, the drug, working? Because it is affecting one of the pathway or the molecule we called the mTOR C1 signaling molecules. Because within these tumor samples, we're seeing that it is very upregulated. And because the tumor is upregulated, this signals means that when we suppress it, the tumor is more likely to be having difficulty to grow. So that's what we're seeing in these tumors. So, and that's why we kind of give an explanation why we're seeing the mTOR inhibitors or sirolimus is working on these patients. But again, we want to know because this figure, I'm saying that when tumor progressed and then when go into the oversurvival, there's a very short interval that it seems that once they progress, the patient cannot stay too long before they pass away. So we want to see how sirolimus is used around the globe institution. Should we use it earlier? Would it be more helpful? So that's why within um, the the ultra rare push program, we're having the POEM study. So POEM study is a study trying to understand the clinical progress, clinical course of EHE patients. And it's a very global initiative. You have institutions from Europe, from Australia, from Taiwan, and also from the US. So we're trying to collect is especially for patients on sirolimus, whether they have started sirolimus or when they start sirolimus, we want to protect how sirolimus is used, how it is affecting the patients, and how long are we really using it. So we want more patient data so we can really see how this drug is helping our patients. If we use it earlier, we actually extend the patient survival, and that is what we want to see. And also, like I said, we want to know why. So for these studies, we're also collecting patients' blood and their tumor samples to understand why sirolimus is working. Do we have further understanding, or even can we now predict whether the patient is going to respond to sirolimus or not? So this is why I'm saying we learn by experience. Lastly, we learn from science. Science is still very important. I'm a physician scientist. I believe in science. And we do understand that for EHE, there is another pathway, what we call the hyposignaling pathway, that may be associated. It's good for our to use drug to target to stop it. So I'm here using a figure to show that when what we call the hippo signaling pathway, when it is on, it kind of activates the YAP-TAZ protein. And you can still remember from the fusion genes that I mentioned, that the YAP-TAZ protein is one of the fusion genes that is affected in EHE. So when this protein actually is activated, it actually kind of degrades the bad proteins and kind of degrades the abnormal proteins so that it kind of remains the homeostasis. But when this pathway is off, it kind of activates a downstream into the DNA, the genome. They use what we call a TEAD protein, which affects how the proteins, the DNA, the RNA, the proteins is going to produced in the cells. And when we look into deeper as to the fused genes, the YAP-TAZ fused genes, it kind of disrupts the balance. So you have these fused genes, the normal protein is not working anymore. So once it's not working, this TEAD, the downstream molecule we call TEAD, will be very activated. And then if we think it later, think it back, because of the fusion gene, the downstream, the TEAD, the TEAD molecule is activating. What if we have a drug that can target the TEAD? So actually there is. So right now there are TEAD inhibitors developing for a lot of cancer patients, but include the EHE patients. So Dr. Candice Haddock has reported in last year at CTOS. So CTOS is the Connective Tissue Oncology Society annual meeting, which she reported a very a promising result by a TEAD inhibitor VT3989 that we're seeing EHE patients either tumor shrink a lot or at least stabilize shrink somehow. And have better control of the disease by using these TEAD inhibitors. And besides the presentation by Dr. Haddox, there's also another company from from Europe. It's called Orion Pharma. They also have a similar TEAD inhibitor that is seeing some interesting activity in EHE patients as well. So we're not only seeing that the sirolimus, we learned by experience that it could be used to be one of the treatment for EH patient. We're also seeing very promising result by novel drugs like the TEAD inhibitors in EHE patients. And this is something the EHE foundations and a lot of the EHE investigators are trying to move forward in the field that for TEAD inhibitors to be able to be accessible or at least in clinical trials for our EHE patients. So that's why I mean we learn by science because we know the underlying what is the driving molecule for EHE. We find a target and we use the drug to stop it. That's why I'm calling we learn by science. So by these three, I think we're seeing a lot of improvement, or at least we're having more understanding for EH patient. I think that's how the global, the specialists, enthusiasts, the foundations are helping move forward for EHE patients. Lastly, I just want to take a few minutes to show that in Taiwan, at least in our institution, National Taiwan University Hospital, we're using the Center of Excellence for Sarcoma. We started in 2023. We're helping all the sarcoma patients, including EHE patients. This is our website. This is a Chinese version, a Mandarin website. You are not easy to find Mandarin kind of sarcoma informations online. So we kind of understand that. So that is a start. And our website right now has up to 150,000 visits. So we're also, the CES is also like the POEM study I mentioned in EHE as well. Lastly, I just want to say that the CES is very important is that we do recognize that sarcoma diagnosis could be wrong. So within our kind of data in the past 2 years, we saw that about almost a quarter of diagnosis would be revised. Right here is a patient who actually came to us. She was diagnosed as angiosarcoma at the outside hospital, but because we had a special technique to test the DNA of this patient. So, and the RNA of this patient, we found that WWTR1 and COMTA1 fusion gene is present in this patient. So we're able to correctly diagnose this patient as EHE. So I think overall, time is short, but in summary, I think I've shown that EHE is an ultra-rare disease, has its unique characteristics, and a highly variable clinical course. Maybe there will be more about this clinical talking tomorrow, but I think we have to bear in mind most of the time it is indolent, but sometimes it could be aggressive. We have to be careful, especially those with diffusions. And the global efforts from organizations such as the PUSH, the EHE Foundation, and ourselves, CES in NTUH, we're trying to advancing our understanding of EHE and improving the treatment strategies. Novel therapies like the TEAD inhibitors that have shown promising early results, and ongoing research continues to further develop these treatment options. So again, I really like to thank our team back home and really want to thank EHE Foundation for inviting me to the 2026 EHE 360. If there's anyone who do interested in any Mandarin sarcoma informations, here's our website, QR code, and really happy to answer question. Thank you.
Thank you, Dr. Chen. That was wonderful. I'm not sure. Can you all see me? Here
Yes.
I am. I'm back now. Thank you, Dr. Chen. I love that you talked about learning from patients and from science. Very important. And we are so grateful for the work that you do in Taiwan, and just appreciate the time and effort that you're giving to the PUSH Consortium and to your work there in the region.